Well, today I want to talk about what I'm going to call the other vascular malformations. Uh, Generally, when people hear the word vascular malformation, there is a tendency to think about arteriovenous malformations, which, as you may well know, these are relatively uncommon unless you happen to be at a referral center. And so you need to be aware of these other malformations because they are much, much more common. So I would prefer that you don't use the term benign because as you'll see, these are not always benign in the way that word is usually used. And so as words can direct our thinking, I think it's best to not consider them necessarily an incidental finding. But by learning these classic MR imaging features, you usually should be able to establish the diagnosis without other testing. But like anything very common, when they're atypical in appearance or atypical in location, they can be quite challenging. And I would think about it in this way. If you have a neighbor down the street that you see all the time, and then you take a trip to another country, halfway around the world, and you see the same neighbor, you may not recognize them as easily because you don't expect to see them in that location. So these vascular malformations, when they have atypical appearances and locations, can be challenging. So I'll show you a couple cases to start. So this is a patient that presents as part of a workup of headache. And you can see this lesion here calcified on the CT scan. And they went on to have an MR scan. This is what it looked like on the susceptibility weighted image, T1 and T2 weighted. So we'll come back to this, but I want you to just consider that case. Another patient presents with acute hydrocephalus. This, of course, is air from placement of an emergent extraventricular drain. You can see the dilated temporal horns, and there's a hemorrhage with an air fluid level in the region of the tectum. We gave gadolinium. There was nothing enhancing. This patient had this enhancing lesion. Here you can see in the region of the hypothalamus, and here's what it looked like on the T2 weighted scan. This definitely was enhancing. And so again, consider these cases. This is what it looked like 2 years later. And finally, this patient who had this glioblastoma, there was this area of enhancement you can see along the posterior limb and the internal capsule. This is what it looked like on the susceptibility weighted imaging. And the consideration was given at the time of multicentric glioma. And finally, this patient who has these vascular structures you can see throughout the left occipital region, here on the surface of the brain, here in the it looks like in the parenchyma of the brain, along the ventricular margin, really quite prominent here on the coronal T1 weighted imaging. So how would you manage this case in this patient with headaches? So we'll start with looking at the vascular malformations that are not visible on angiograms. And so these used to be called occult vascular malformations, and these are capillary telangiectasia and cavernomas, also known as cavernous angiomas and cerebral cavernous malformations, and sometimes abbreviated as CCMs. Is there a standard terminology that's used in Armenia? Do you call these cavernomas or cavernous malformations? Anyone? No standard language, that's fine. So
we call cavernous malformations.
We'll start with, and then we'll talk about vascular malformations that are visible on angiography. And these are the venous angiomas or developmental venous malformations, and these are usually visible, and these are differentiated from AVMs based on the absence of early draining veins. Some of these vascular malformations can cause symptoms, but not all of them. And so I'll order these in terms of the ones least likely to be symptomatic to more likely to be symptomatic, or most likely. And keep in mind that you can have mixed lesions that have features of both one type of malformation and another. The most common of these are the developmental DVAs along with cavernomas. So we'll start with capillary telangiectasia. So again, these are, as far as I have seen, are never symptomatic. The biggest issue with them is that they can be mistaken for something else. So these are solitary. They're seen most often in the ponds. I apologize. I don't know why we're getting that drift. Here you can see on this autopsy specimen, this is a relatively large capillary telangiectasia, but you notice how you see the normal structure of the brain through it. These are dilated capillaries. Typically seen is stippled enhancement with little or no abnormality on T2 weighted imaging. And while they do not hemorrhage, they can show evidence of signal loss on susceptibility weighted imaging. This is what the histology of a capillary telangiectasia looks like. Again, dilated capillaries. You can see the red blood cells in here with normal brain intervening. This is what a typical capillary telangiectasia looks like on MR imaging. So here you can see this area of enhancement in the pons, and you can see why these can be difficult in patients with metastatic disease, where this is exactly what you're looking for, is an enhancing focus. Now, in a patient with cancer, for example, small cell lung cancer, when you see a lesion like this, I think the prudent thing to do is just to bring them back for a follow-up scan. What I think would be a mistake is to just call it a metastatic lesion and then go on to, say, radiation therapy. So again, be aware when you see these areas of enhancement. The way I approach them is I look to see if on the susceptibility weighted imaging, they're dark. And if they're in a typical location, I would favor capillary telangiectasia. But as I say, in patients with a possibility of metastatic disease, it's difficult to entirely differentiate them. Here's another one in a less common location. Here you can, this is the one I just showed you. You can see there's a little bit of a prominent vein associated with this. So this is probably a mixed lesion of capillary telangiectasia and a developmental venous anomaly. You can see this blush of enhancement here. There's really no signal abnormality on the T2 weighted imaging. And we ended up following this one, instead of being a few months, came back 2 years later and looked basically the same, accounting for differences in the imaging technique. So again, atypical location, but relatively typical appearance. Here's another one. You can see this area of stippled enhancement in the cortex medially, and this is another capillary telangiectasia. Here's one, again, you see this prominent vascular structure that enhances, and this blush of enhancement in the cortex. No real signal abnormality on the FLAIR scan, nothing on the T2 weighted scan, and you can get a hint of it maybe on the T1 weighted imaging. So again, these are all atypical capillary telangiectasias. This one atypical, even though it's in the pons, there actually are 2 lesions. This was supported by other imaging planes, and so no signal abnormality here on the FLAIR scan. Here's another capillary telangiectasia, again, stippled enhancement in the pons. This one had a little bit of signal abnormality on the T2 weighted scan. Again, really not enough to suggest a different diagnosis. And this is what it looked like on the susceptibility weighted imaging. Notice the signal dropout associated with this, which is typical for capillary telangiectasia.
Sorry, Alex, have you seen any cases when you don't have signal drop off on SWI?
You know, I apologize. I'm not actually, let me just see what's going on with my volume here. I can't hear you.
Can you hear me now?
Could you try again?
Yes. Can you hear me?
Now I can, yes. Sorry.
Okay. Have you seen any cases where there is no drop off signal on SWI?
Yes. It's not in every case. And what's very common where sometimes people get carried away is in patients that have had, say, shallow flip angle gradient echo imaging, and then on follow-up have an SWI scan, or they have a scan at 1.5T, then they have 3T. So the conspicuity of the signal dropout from susceptibility effect, of course, varies with the sensitivity of the pulse sequence and the field strength of the scanner. So I think that accounts for some of the cases where it's when it's done with low field and maybe not with a true SWI scan, you may not see this effect.
Okay, thank you.
This is a complex lesion or a mixed lesion. Here you can see CT scan, nothing really to be seen. This patient had HIV, so we had a high index of suspicion we were going to find something. Here you can see this blush of of enhancement in the region of the thalamus, and then some vascular structures within. Again, probably a combination lesion of a DVA with a capillary telangiectasia. This is that same case. You can notice on the FLAIR scan, there's no signal abnormality. This is actually the diffusion scan, and there's no real signal dropout in this case. And here you see it on the coronal imaging. There's the vascular structure. So again, don't be misled when you have these complex lesions. And as I said, and we'll get to this a little bit, but it's always tempting when you see atypical lesions to consider the possibility of a true arteriovenous malformation. But the reason I would argue against an arteriovenous malformation in a case like this is that normally the vascular structures that you see in an AVM are high velocity flow, and they won't show homogeneous enhancement after administration of contrast, particularly when you're using a 3D acquisition like MP-RAGE. Again, just another typical, this one's in the midline, capillary telangiectasia, quite a bit of enhancement here, nothing to be seen here on the FLAIR scan. So again, when you see this, I think your go-to diagnosis is going to be capillary telangiectasia. Now, if we look on this case, you can see there's quite a bit of blush here, and there's actually a prominent basal vein of Rosenthal on this side. So again, very tempting to suggest the possibility of an arteriovenous malformation. But when you see this homogeneous enhancement of all of the vascular structures, you should be less inclined to think about arteriovenous malformations, because usually there's high velocity flow, which will blunt that. Now, what can you do in cases like this, which is a little thought-provoking when you have an asymmetric draining vein? So this proved to be just what appears to be on this scan, a DVA with a capillary telangiectasia. But when you are uncertain and you're going to have a small percentage of cases where you're going to say, I don't know, which is fine, that in those cases, you have a few options. One is to do a 3D time of flight MRA. Remember on 3D time of flight MRA that you really only see high velocity flow. So if you recover vascular structures on the 3D time of flight MRA, you're probably dealing with an arteriovenous malformation. A second option is to do one of these MR tagging scans where you can determine if there's AV shunting. Not typically done, but you'll notice on susceptibility weighted imaging, oftentimes you'll see a difference in the appearance of veins and arteries. So even a standard SWI scan can often help you in making the distinction. And then, of course, the last resort is to do a conventional angiogram, which is not the end of the world. These are often young patients, and the risk of cerebral angiography is really quite low. And as I say, there will be cases where there'll be some uncertainty. And in cases where there's hemorrhage, I think you're probably obliged, in cases which have atypical features, to go on to angiography. So again, important to recognize that capillary telangiectasias are not associated with symptoms, but they often are mistaken for metastatic disease. As I've shown you, they're more troublesome when they're outside the brainstem. And if you're uncertain, just get a follow-up in 3 to 6 months. This is the case I showed you at the beginning. And when you're inclined to think that this second lesion is the same as this, which is certainly a reasonable consideration, Notice the sharp delineation of this lesion on the SWI scan. And then this is the follow-up. The patients had their primary tumor resected. They've had a good response to treatment, and notice that this lesion looks unchanged. This is 6 months later. So this is a patient of two different diseases manifesting on the same patient with a capillary telangiectasia and a primary brain tumor. But important to recognize in this case, because if you have an aggressive surgeon who for whatever reason considers going after that second enhancing lesion, this would of course entail much greater morbidity for the patient. So I think it's important to, at least in this case, broach the possibility that this is an unrelated disease, and as is, I believe, proved to be over time, as this is unchanged over years, that this is a capillary telangiectasia. So let's move on to the next category of developmental venous anomaly. These are often called venous angiomas. Again, different terminology that's used for them, but in the end, these are enlarged medullary venous channels that tend to drain to a central vein that is oriented perpendicular to the cortex or ventricular margin. And for those of you with some classic education, remember the caput, the medusa head. Oftentimes these veins, small veins that all congregate in a single vein, people feel resembles the the head of Medusa. And because they drain normal vein, these should be considered normal variants and left alone. So particularly in patients with cavernous angiomas that are thought to be symptomatic, let's say presumed to be a site of symptoms of epilepsy, that it's important that the surgeon be aware of the DVA so that these are not resected inadvertently. So the draining vein is usually what is evident on CT and sometimes on MR, but remember that the spoke wheel or Medusa head is very typical, and this is what it looks like on a conventional angiogram. You see these numerous venous channels. We're in an early venous phase here. You can see some early veins appearing. And then on the next frame, as we start to see, here's internal cerebral vein, normal vein is appearing, vein lobae is appearing, and now we see the draining vein. So this is the hallmark of a typical DVA, even though this is a large DVA. It behaves in a way that supports the diagnosis in that the draining vein appears at the same time as normal venous structures in the brain. If you contrast this with this patient who has this congregation of veins, probably a dilated vascular structure here, you notice there is an early appearance of a vein here because we're in a mid-arterial phase on the angiogram here. So this is an arteriovenous malformation, not a DVA. This is what they look like oftentimes on CT, where you may not resolve the small branches of the caput and medusa, and you only see the large draining vein. Here's another one. This is on MR, but again, you see the enhancement of the vein. Now, important to keep in mind as you think about this distinction between arteriovenous malformation and a DVA, that on conventional, in this case, MP-RAGE or some similar 3D T1 technique, all of the vascular structures enhance. And this is what argues against the presence of high velocity flow within the lesion, which would make it more typical for a vascular malformation, an arteriovenous malformation. Here's another, not a great quality CT scan, but you can see another DVA. And here's the DVA here again on angiography. And notice the timing that we see the draining vein in the same sequence as the transverse sinus and sigmoid sinus on this side, along with other normal venous structures. Here is a large draining vein with the caput and medusa, or these dilated medullary veins, seen on a separate slice, but put together, this is the typical appearance of a DVA. Now, in this case, you'll notice a little bit of signal dropout here, which is more evident on the gradient echo scan. And this is the typical appearance of a mixed lesion in that this patient has a cavernoma and a DVA. and we'll come to this a little later, but these are frequently seen together. Usually the cavernoma is in the draining bed of the DVA, and they may be causally related. Now, this case I showed you at the beginning, and this to me is a good example of a case where the physicians reading the case did not feel comfortable just calling it a DVA. Now, what do we see? Numerous dilated vascular channels, large veins here on the surface of the brain, large cortical veins, all this enhancement in the sulci. But you'll notice on these images that all of the vascular structures homogeneously enhance. There are no flow voids visible on these sequences. There's no evidence of hemorrhage. And you notice on the SWI scan that just like the thalamus striate vein, the internal cerebral veins, all of these veins are dark. Now remember, oftentimes on SWI scan, the arteries will have a higher signal intensity. So this is a typical appearance of a venous structure. This patient went on to have angiography, and I think that was a reasonable decision because of the size of the lesion. And as we look at the angiogram, here we are, if you think about how you would go about doing this angiogram. So again, for those of you that read angiography or do angiography, remember that the goal in an angiogram in a case like this is to deliver the contrast in a compact bolus so that you have clearly defined vascular phases. So you can define the early arterial, the mid arterial, the late arterial, the capillary, the early venous. You should be able to see all of those phases. And if you do a hand injection, I think there's a greater likelihood that you will slur the contrast injection and may be misled sometimes in terms of establishing the different vascular phases. So as I look at this, I would say we're in mid arterial here, we're in late arterial capillary here. Now we don't really see much here, right? So if you go, now we are in this capillary phase. We still don't see any veins. Now we're starting to see the cortical veins over the frontal lobes, which are oftentimes the first cortical veins that we see. They start to progress posteriorly. Now you see these large, unusual vascular structures. So this sequence of imaging establishes the diagnosis in this patient that this represents a large, unusual, I'll admit that, but this is a large DVA and not an arteriovenous malformation, regardless of its size or odd appearance. So, and again, a good example of a case which is at the fringes of what I think a reasonable person would feel comfortable saying without a doubt, this is a DVA. Now, one thing you'll see sometimes in DVAs is you can see some T2 prolongation in the region of the caput. And this doesn't really have a known significance. There are different theories as to why this occurs. The most reasonable one, I think, is that there may be some venous hypertension associated with the draining vein, either from kinking of the vein or chronic flow, whatever. If there is some impaired flow, you may see some T2 signal abnormality, but I wouldn't suggest that that requires any treatment or that this is a different entity based on that appearance. So just be aware of that variation of appearance. Now, can DVAs cause symptoms? This is a very unusual case we reported years ago, but this was a DVA that was in the region of the midbrain and the tectum and actually caused aqueductal stenosis. And this patient presented with an adult pattern of aqueductal stenosis. So again, I show that as an oddity. Now, this is a more uncommon, but somewhat more common situation. This is a young patient who was told at some point in her terms of medical workup that she had some sort of brain vascular malformation. She came to, this is actually the first case I saw when I came to Philadelphia at the hospital in the first week. This woman came in, she was postpartum, she was home, but she had a seizure and presented to the ER. So what do we see in this case? So on the FLAIR scan, we see some high signal intensity in this region. We see what looks kind of like DVA. and a draining vein. But what's unusual about it is that you see this is not an SWI scan. This is a shallow flip angle gradient scan, which is a very good technique for establishing thrombosed cortical veins. And in this case, was consistent with thrombosis of the draining vein. And here you see on the enhanced portion of the scan, the draining vein does not enhance homogeneously. So we see the caput, but you don't see enhancement of the draining vein. So this is a patient with a thrombosed developmental venous anomaly. Now, as improbable as that sounds, and that was my reaction to this when I saw my first case of it, I have seen a few cases since then, and I have considered it in cases which sort of we were baffled and couldn't find any better explanation. And I think this is a reasonable consideration, just like we think about cortical vein thrombosis. So the draining vein can occlude or become stenotic, and this can be associated with a venous infarct or hemorrhage. But while these are not commonly reported, there probably are a number of cases that were missed. And this is the first one I saw. So this patient was transferred from an outside hospital. You can see this high attenuation structure here. If you follow it down lower here, you see it here, you see it here. Patient, this is the reconstruction. Notice it's of high attenuation. Patient went on and had this MRA at our, MR scan at our hospital. Again, you see the signal dropout in the draining vein. You see this cortical thickening and abnormal T2 relaxation time, and you see the enhancement of the caput. So if you think about the hemodynamics in this case, we have a large DVA, which is draining in a sense to nowhere, right? If the draining vein is thrombosed, there's no place for that blood flow to go. And this is a normal venous structure. So there really it's not reasonable to assume that there are other collateral pathways that allow venous drainage. And so while we were discussing this case, the patient had a neurologic emergency, was sent back down for a CT scan, and the patient 4 hours later, from the time of the MR scan, had this large hemorrhage, and patient perished. And this was a large venous infarction from a thrombosed DVA. So as I pointed out, the first category of capillary telangiectasia, never really symptomatic, usually mistaken for other disease. DVAs almost never symptomatic, but can be symptomatic either from mass effect. And one other example I will offer in that is in patients with tic-douloureux have been reported to have cavernous developmental venous anomalies in the region of the fifth cranial nerve. And then we're going to move to this last category. These are cavernomas. And I'll offer these questions for you to think about. Cavernomas never have mass effect. Cavernomas are congenital and don't appear. Cavernomas are always intraaxial. I offer these because I think these are conventional ways of thinking about cavernomas, and these are all false. Cavernomas can have substantial mass effect. These are usually seen early on, and we follow them over time, but you will see cases where they appear. De novo appearance of cavernomas is unusual in patients who've not received previous radiation, but it does happen. And cavernomas are not always intraaxial. You will see extraaxial cases, and I'll show you a couple of cases I saw in my experience. Now, this number to me doesn't mean a lot. I will say these are really pretty common, but they can be multiple and they can be familial. So you want to look, if you see one, you want to look for other ones. And the problem with them is the natural history is not really certain. The risk here you can see they list as 0.5% to 5%. That's a 10-fold variation. And so you can't really think in terms of resecting all cavernomas. It really depends on their location, whether they've hemorrhaged, whether they're growing, and location is really important. So the brainstem ones are more often symptomatic and our surgery in a more expedient way than, say, a cavernoma that you identify in the frontal lobe that's never hemorrhaged and is not really associated with any symptoms. The important piece of information you need to understand about cavernomas, which will help you to understand how these get operated on, is that these are dilated vascular channels with no intervening brain. And that's important because when you're imaging, if the patient is in any way a surgical candidate, what you need to establish for the surgeons is, does the cavernoma approach the pia in any part of the brain? If it approaches the pia and there is a surgical conduit to the cavernoma, then these can be resected from the inside out. So the surgeon doesn't have to go through the brain or worry about removing normal brain. They basically shell these out like you might shell out an avocado, leave the rim in place if the patient doesn't have epilepsy. And that way they can decrease the risk of hemorrhage without significant morbidity in good hands. So this one I showed you at the beginning, this I thought was an unusual appearance. This one is fairly calcified. Here you see it on the, I think this is a gradient scan. You actually see probably another one here. And you notice the dark hemosiderin rim here if you look carefully on the T2 weighted scan. So this is a densely calcified cavernoma. And this was resected, actually. This patient had symptoms and this was resected and proven to be a cavernoma. So this, I think, is at the extreme of calcifications. I've seen a number of cases after trauma where they get a CT scan in the ER after a fall, bike accident, car accident, and these are mistaken for hemorrhage. And requires unnecessary follow-up. So be careful about that. If you, for example, you think you're looking at hemorrhage, but the nature of the trauma, is kind of minor, they fell out of bed, you want to at least consider a cavernoma. And remember that usually on the T2 weighted scan, they have this very typical appearance of this dark hemosiderin ring. They may have, excuse me, T1 shortening on the T1 weighted imaging, and always have this susceptibility effect once they get to this size. Now, brainstem cavernomas are a little different. This is an older article, but I just want to point out in this meta-analysis, they had 30 cases that were managed conservatively, meaning they did not have surgery, and at a follow-up of 3 years, 34% of the patients were moderately to severe disabled or dead. So they're in patients that you see with a hemorrhage from a brainstem cavernoma, I think that they should at least be considered for surgical resection because of the risk over time of morbidity or mortality associated with a second hemorrhage. Now, cavernous angiomas are best demonstrated on either shallow flip angle gradient or really best seen on SWI imaging. And that is because we're looking for the susceptibility effect of the hemosiderin from repeated hemorrhage. These can be inapparent on fast echo T2 weighted imaging, particularly when they're small. That's why I would say when you're doing epilepsy imaging, you need to include some sort of gradient echo or SWI imaging if you're going to identify the cavernomas. Look for the complete hemosiderin ring, and complete is an important part of that concept because incomplete hemosiderin rings oftentimes is seen when you're looking at hemorrhagic metastatic lesions, and there can be difficult to distinguish at times. These are rarely seen within the ventricles or the extraaxial space, particularly the cavernous sinus region, so be very careful about that. I'll try to show you a couple cases. Now, this is obviously an autopsy specimen from the brain, but what you see is the hemosiderin staining of the brain parenchyma and this spongy material here at the center of this large cavernoma. This is what the surgeons will resect. So they can operate, once they get inside the cavernoma, they can resect it from the inside and leave this hemosiderin brain of normal, in a sense, normal functioning brain at the periphery. Now, in cases of epilepsy, I have, my understanding is that they often try to resect some of this hemosiderin staining to try to decrease any risk of this being an epileptogenic focus as a result of the hemosiderin staining. But so the approach is a little bit different, I think, by some surgeons in cases of epilepsy. But I think this demonstrates the concept for you, this idea that there's no brain inside the cavernoma. And then you see this on the histologic section. These are these dilated venous channels, and there's no intervening brain here. So that allows them to resect. Like, for example, this case, you see this large cavernoma with mass effect, complete hemosiderin ring, mixed signal centrally. Sometimes that terminology is used, a popcorn appearance. Now, this does come to the ventricular margin. So with a posterior approach through the ventricle, this could be resected from the inside to the rim, and in a sense, decrease the patient's risk of additional hemorrhages without worrying about injury to the multiple, critical structures within the brainstem. Here's another, this is a T1 MR scan showing you these multiple areas of T1 shortening, fairly typical of a cavernoma. Now, this is one of the problems that you'll confront. This patient comes in with this lesion in the temporal lobe near the hippocampus, and it shows this hemorrhage, and this went on to resection. This was acute hemorrhage in a cavernoma. So I think in young patients with hemorrhages, the differential for you oftentimes will be hemorrhage of an unknown cavernoma or arteriovenous malformation. And when they cause seizures, then of course that is something that you sort of add to the analysis. Now, this was a problematic case. This was a 50-year-old presented with acute hydrocephalus. And here you see the fluid level. Now, we were thinking about aggressive neoplasms. Generally, metastatic lesions and aggressive neoplasms are the ones that hemorrhage, but we were puzzled because there was no enhancing tissue whatsoever, which would be unusual for even a hemorrhagic neoplasm to see the absence of any enhancement. So the surgeons chose to follow this case. Now you see as the hemorrhage resolves, again, there was no abnormal enhancement, but it takes on the appearance of a more typical cavernoma. And we followed this actually regressed over time. And this was a tectal cavernoma. And the patient was spared the potential morbidity from surgery of this lesion at the outset. So again, when you have unexplained hemorrhages that are angiography negative for vascular malformation, particularly when you're dealing with the brainstem, you want to at least consider the possibility of a hemorrhage in a cavernoma. Cavernomas can also occur outside the brain. This was a spinal cord cavernoma that we followed for some years and was unchanging. These usually don't require surgery. Again, people try to avoid that for the risk of surgery, but in rare cases may require that. But just be, the appearance will be pretty much the same in the spinal cord. And then this was a 16-year-old with headaches, and you can see this is kind of the classic appearance of a cavernoma, multiple areas of T1 shortening. Here's another one, dark hemosiderin ring. So I'm just showing you typical appearances. Here again, see this dark hemosiderin ring, and another area of susceptibility effect. And so as we expect, many of these patients with cavernomas will have more than one lesion. Now, this was sort of getting to my point of like anything common, atypical features and locations will challenge you. This patient had an we thought was intraventricular mass that enhanced quite a bit, but not homogeneously, and had a little bit of hemorrhage. And I was happy to say this was our fellow at the time, Becky Benz, noticed this siderosis around the brain stem. And so this was an indication that this lesion had been hemorrhaging in the past. So while you might be tempted to consider the possibility here of an intraventricular meningioma, the enhancement pattern is not typical. The T1 shortening is not typical. And so even though this is not a typical location, this is a fairly typical appearance for a cavernoma. And this patient actually went to surgery and this was resected. And this is what it looked like on the T1 weighted scan. And I think you'll agree this is not a typical appearance of a meningioma. And the siderosis is not common with primary brain tumors. And this proved to be an intraventricular cavernoma. Or I guess you could argue maybe a cavernoma in the wall, in the sort of subependymal space that projected into the ventricle. But again, atypical location of a common disease. And then this one is a quite uncommon case. Here you can see this mass that's along the falx that you see it enhances quite homogeneously. There's not much dural tail. It's quite bright on the T2 weighted scan. You occasionally see that with meningiomas, although it's not common. And in this location, I think you'd be hard pressed. But this went to surgery and this proved to be an extraaxial cavernoma. And I just want to bring that to your attention. Particularly, we saw a case like this recently, not as large as this, but was thought to be initially to be a cavernous meningioma. But if you think you're looking at a cavernous meningioma and it's bright on the T2 scan, so it has a long T2 relaxation time, you should consider the possibility of an extraaxial cavernoma, and that is a don't touch me lesion. That for the surgeons, you're doing the patient and the surgeon a big favor by suggesting that diagnosis, because they will be very difficult to manage at surgery due to the bleeding that can occur when you operate in that location on a cavernoma. So keep that in mind. When you see what you think is an atypical meningioma, you may be looking at an extraaxial cavernoma. Now, when you see multiple hemorrhages, there is a differential to consider, right? You want to consider if there's a setting of trauma. We know you can see multiple shear hemorrhages. If the patient's over 70, you want to consider amyloid angiopathy. If the patient has a history of radiation therapy, you'll often see multiple areas of susceptibility effect. The big problem usually comes up when we're dealing with hemorrhagic Mets, vasculitis. Hypertension is fairly typical because you'll see these susceptibility effects in the basal ganglia as well, but don't always offer multiple cavernomas in your differential. Here's a case. This is a typical appearance here of a cavernoma again, and you notice that it looks larger on the gradient echo scan, and this is a property called blooming, which is a feature of susceptibility effect. And again, this patient has a second one. This is a patient with head trauma. You notice these multiple hemorrhages at the gray-white interface. These are typical for shear type hemorrhages. You'll also notice that they're very difficult to see on the T2 fast spin echo imaging. And this is a feature of fast spin echo, is that it has a relatively low sensitivity to susceptibility effect. That's a good thing when you're doing spine imaging in patients with hardware. That's not so good when you're looking for hemorrhage in the brain. This is a patient with a history of hypertension. You'll notice there's areas of susceptibility effect in the basal ganglia, as well as the white matter and gray-white junction, but this is a fairly typical appearance of hypertension. In terms of treatment, radiation was not recommended for a long time, but I've noticed that there's been some resurgence of interest, but it's usually not the first choice, I think, in patients with symptomatic cavernomas. And we talked a little bit about intractable epilepsy and the fact that brainstem and midbrain lesions that you would think ordinarily would be inoperable have been resected with good results, because with careful selection of surgical routes and planning and the cavernoma coming to a surface of the brain, they do allow low morbidity surgery. Keep in mind that many unexplained brain parenchymal hemorrhages can be attributed to a cavernoma, but you shouldn't limit your diagnosis to that possibility, that some of these cases will require angiography. And if the angiography is negative, usually with 2 angiograms, then I think you may be more confident of the diagnosis. Now, can you always differentiate an AVM from these other vascular malformations? And keep in mind that AV shunting cannot be determined on conventional imaging. So to make a final determination, usually DSA is required. But one thing that can help you, as I say, is on 3D time of flight MRA, you shouldn't see high velocity flow. and the flow, there shouldn't be any flow voids within the lesion. Now, here's a patient with a lesion here. You notice that it's along the Sylvian fissure. So a reasonable question here is going to be, number one, is this even intraparenchymal? But you'll notice on the 3D time of flight MRA, there's a lot of signal here. Here you can see the middle cerebral branches and in this lesion as well. So there shouldn't be any consideration. This is a cavernoma. This is a vascular malformation. This is a nidus. And so that's one way you can differentiate an AVM from a vascular malformation. This one's a little more difficult. You could argue these are like sort of stippled enhancement that you see sometimes in cavernomas, but you'll notice that the internal cerebral vein on this side enhances homogeneously and not on the side of the lesion, which tells you that you have high velocity flow in this vessel with intravoxel dephasing, and that this is an arteriovenous malformation, not a cavernoma with a DVA. And then finally, this patient, which in some features resembles a cavernoma, right, with a dark hemosiderin ring, but unfortunately aneurysms have the same appearance. And if you look at the pattern of T1 shortening, it's not that dot-like sort of popcorn appearance you see in cavernous malformations. This should alert you to the fact that this could be a giant aneurysm, and that's what this proved to be. Here you see on the CTA, and this is what's called a serpiginous aneurysm. These are atypical aneurysms, but again, you have to be aware of these variations and don't get too dogmatic about establishing a diagnosis. In a case like this where you say to yourself, well, I'm not sure, that's fine. As I say, a certain percentage of cases, you're going to be uncertain, and then it's very reasonable to go ahead and order other studies like MRA, CTA, or conventional angiography. Don't be sort of ashamed if you can't make the diagnosis from the MR scan alone. And then we'll finish up with these mixed lesions. I'll show you a couple of these lesions, but the theory has been advanced that the elevated venous pressures from the DVA or capillary telangiectasia can be the source of formation for a cavernoma. So here's a large DVA in the cerebellum associated with a area of signal loss, which is typical for a cavernoma. So this is a mixed lesion. Here's another one. You see the cavernoma, and if you look on the contrast scan, you see the DVA. So look for these together. And it is said that at the time of operation, almost all brainstem and midbrain cavernomas have an associated DVA, as this one did. You won't see them in every case, but you'll see them if you look for them. Here's another one. This was another cavernous malformation associated with DVA. Now, I'll bring you the last category that is a relatively new concept, and I find is a really troublesome one because it really does push you to angiography in a lot of cases, that there are lesions that look like DVAs, but can in fact be arteriovenous malformations. And these are usually called venous predominant AVMs. Now, here's a patient we had who had a hemorrhage, had a CTA. This looks like a DVA on this MIP image from the patient's CTA, but the patient went on to angiography, and here you can see this early appearance of a vein with this blush that looks like a caput medusa, but look at the timing, right? You're seeing the vein at a late arterial phase. So this was a DVA that, this was an arteriovenous malformation, which looks, say, 90% like a DVA, but is in truth an arteriovenous an AVM. So be careful about being, again, too dogmatic, and don't be afraid to go to angiography when there's any question. And so before you make the diagnosis of an arteriovenous malformation, look at all the pulse sequences. Let's see if I can get this to run. Here, I just want to show you this case. Here you see this lesion here in the parieto-occipital region with some high attenuation. Not much to look at on this non-contrast scan. This is what it looks like on the MR scan, T2 weighted scan. Could this be a DVA? look on the post-contrast imaging, you see the flow voids here. So again, this violates that rule that I stick with, is that on T2 weighted imaging, you should have homogeneous enhancement of the draining structures if you're dealing with the DVA. And so this proved to be an arteriovenous malformation. This was a patient with pulsatile tinnitus, and there's not a lot to look at here, but I want you to notice that this is part of an MRA, and you see this large transcortical vessel, and you see this little bit of high signal intensity in the region of the sinus. And this is enough, I think, in a patient with pulsatile tinnitus to consider the possibility of a dural fistula. And here you see the large occipital branch of the external carotid with early appearance of the transverse sinus in this patient with a dural fistula. Dural fistulas are usually associated with abnormalities of the adjacent dural sinus, and conventional angiography is usually needed for treatment decisions. So, in summary, it's a big, fast run through a big topic. And I think for those of you that look at MR regularly, you're pretty familiar with these vascular malformations. But I wanted to show you some of these variations of this common disease to sort of open your eyes to the variations in their appearance. These are very common. They're frequently mistaken for other disease. And I've had this experience, maybe you have too, where patients will get referred into our neurosurgery clinic with what are thought to be some significant disease at an outside hospital. But in truth, when you look at the imaging, you feel pretty confident that you're dealing with a vascular malformation. But you're going to see variations in location and character, and use all of your tools, MR, CT, SWI, and when necessary, DSA, to characterize these lesions. Well, that's all I have to show you today, and I'd be happy to take any questions. No questions? Well, thank you very much for joining me today, and I hope that was valuable for you.
I'm sorry.
Yes.
I have one question. First of all, I would like to thank for your time. I have a question about capillary telangiectasia located within the cortex. Can it cause seizures?
No, I don't believe so. So I feel that DVAs and capillary telangiectasias should not be thought to be the source of seizures. Now, you have to be careful and be aware that, you know, I would, when you call it a capillary telangiectasia, you want to make sure you have good quality SWI imaging, because they can coexist. So if you have a cavernoma, that could be the source of seizures. But I think that it's probably a red herring, unless, now again, I mean, maybe you have a case like this where all the electrical studies point to the same location as a capillary telangiectasia. But in my experience, I've never seen a capillary telangiectasia that was a source of seizures.
Okay, thanks. And second question, how to differentiate from, for example, capillary telangiectasia located within the pons between hemorrhagic metastatic disease. Why am I asking? Because I had a question. I had a patient with hemorrhagic metastasis all over the brain, in the cerebellum. And is it principle to differentiate them, or maybe we can interpret them as an hemorrhagic metastasis because the patient will go to chemotherapy or radiation? What do you think about that?
Well, that's a challenging problem. So unless it behaves differently than the other lesions, then I think the only thing you could depend on, I think, would be that its behavior over time. But if the patient is, as you say, undergoing therapy, and I think that would be a difficult situation if the patient had metastatic disease elsewhere and they were planning to do gamma knife and they were asking, you know, 100% confidence, is this a hemorrhagic met or a capillary telangiectasia? I guess the one thing that may help you is that if it has no signal abnormality on FLAIR or T2 weighted imaging, it's not, it's less likely, but I don't think you can ever get to 100% confidence.
Mhm.
And so you're going to end up in a situation where you may be over treating some patients and under treating some patients, depending on how you decide. But I think in that particular circumstance, the only thing you can depend on is how it evolves over time.
Thank you. Be healthy.